Welcome to the Opioid Prescriber Training Program. I'm Ed Bednarczyk, Director of the Center for Health Outcomes, Pharmacoinformatics, and Epidemiology at the University at Buffalo. This module is part of the mandated prescriber training program in the state of New York, and this first session will cover two of the areas of mandated training. First, by a little bit of a way of background, why are we here? How did we get to this point of requiring mandated training? Well, we are in the midst of an opioid epidemic, and specifically, we're in the midst of an epidemic of overdose deaths involving opioids. These are data from the CDC looking at deaths from any opioids, from commonly prescribed opioids, as well as street drugs such as heroin, synthetic opioids such as carfentanil, and the like. In New York State, we unfortunately mirror these trends with a bit of plateauing being seen for prescribed opioids, but a continued rise in the deaths due to all other classes of opioids. To combat this problem, New York State has launched a series of steps to mitigate the problem, not any one of which are expected to solve or reverse the trend, but these include the Internet System for Tracking of Overprescribing, better known as ISTOP, as well as legislation requiring prescriber education. So the question is, who is required to complete the mandated prescriber opioid training? Any prescriber with a DEA number, as well as medical residents who are prescribing under a facility DEA number. The program has to consist of 3 contact hours of coursework or other training in pain management, palliative care, and addiction. Initial compliance was expected by June 30th of 2017, but all new practitioners are expected to comply after this date and then every 3 years thereafter. The training will include, but not limited to, pain management, appropriate prescribing, managing acute pain, state and federal requirements for prescribing controlled substances. It's these first 4 points that are going to be covered in part 1 of the course. The objectives are to describe the pathophysiology and general approaches for pain assessment in the ambulatory setting, to describe approaches for managing acute pain and how they differ from approaches for managing chronic pain, and to outline clinical guidelines for appropriate prescribing of opioid analgesics, and finally list the federal and New York State requirements for prescribing controlled substances.
Hi, this is the Opioid Prescriber Training Program Part 1. My name is Carl Fiebelkorn. I'm Senior Associate Dean at the UB School of Pharmacy and Pharmaceutical Sciences. I'm going to be talking to you today about the laws, rules, and regulations concerning the prescribing of controlled substance in New York State. Controlled Substance Schedules and Controlled Substance Act is found in 2 different places. The federal law under the Controlled Substance Act, and there's an HTML for you to follow. It's under Title 21 of the Code of Federal Regulations. And in New York State, it's under the New York State Department of Health Bureau of Narcotic Enforcement, and there's also an HTML you can go to. We look at Article 33, which is statutory law, and Part 80 and Part 910, which is part of the regulations. Purpose of issuing a prescription is for a legitimate medical purpose, and the responsibility is upon the prescriber who actually does that. There's also a corresponding responsibility that rests with the pharmacist. And the pharmacist is also liable for that also. So any kind of questions might be directed back to you when a pharmacist has questions on those prescriptions. Pharmacy must make a good faith effort to verify your identity or anybody who's picking up that prescription for any dispensed prescription for a controlled substance by requiring such person, if unknown to the pharmacy or pharmacist, to present the appropriate identification. Prescribers may use controlled substance in the treatment of their patients, but not for addiction, when the prescriber regulates the dosage, administers or prescribes a quantity no greater than any other person or prescriber in that proper treatment of that patient as an ordinary prescriber. Different types of prescriptions, thought I'd run through this rather quickly. Obviously, there's written prescriptions in New York State that's known as the official New York State prescription blank. There's exceptions to that, which are out-of-state prescriptions, which can be written on a white blank, as they would call it, or the blanks of any other state. So this would be for prescribers not practicing in New York State or clinics or hospitals on federal land. So that might be the Veterans Administration, Indian reservations, or military bases, such as Fort Drum in New York State. There's also verbal prescriptions. I'm just going to quickly go through those. Electronic prescriptions, and there's also faxing. A written prescription looks like this. This is an official New York State prescription. Not going to spend any time on that, but that's just a basic prescription, everything that obviously needs to fill out. The written prescriptions are sensitive to heat and light, so you can actually press part of the prescription to see it change color. Written prescriptions in New York State must be the official New York State prescription blank and must contain the signature of the prescriber. There's a lot of security features on that blank itself, such as barcodes and serial numbers and so on and so forth. Prescriber's name must be imprinted or stamped legibly and conspicuously on the blank. So if you're working in a clinic or a hospital, you should have a stamp with your name on it with a DEA number that you can stamp on the emergency room blank or the blanks for the hospital when you're discharging patients. Other than that, they should be made out with your name already imprinted on them. There's different rules of thumb. We didn't talk about verbal prescriptions and fax prescriptions, but basically electronic prescriptions, the same information as you would have on written prescriptions, and a fax prescription would be the same information you would have as a verbal prescription. Fax are actually telephonic, they're not electronic. Verbal prescriptions and fax, C2s, anabolic steroids, and benzodiazepines, you have to have a follow-up within 72 hours via written prescription sent to the pharmacy or delivered to the pharmacy or electronic. Follow-up must state authorization for emergency dispensing, and otherwise we as pharmacists have to report you to the Bureau of Narcotic Enforcement or DEA if we don't get a cover. C3s or C4s, non-benzodiazepines, and C5s, you have to send it within 72 hours. Persons authorized to issue verbal prescriptions, the federal law says that an agent or an employee of that individual practitioner can call them in. New York State does not allow that. You are required as a practitioner to personally call those in to the pharmacy in any venue, whether it be hospital, clinics, or wherever it may be. New York State requires on a written prescription or any kind of fax prescription going into the pharmacy, it has to have one drug per blank on the prescription. So no drug shall be dispensed by a pharmacy when such prescription form includes any other drug. Exceptions to the one drug per blank, more than one non-controlled substance may be written on an inpatient or medical order, okay, for like a residential healthcare facility. Any other Article 28 facilities, mental health hospitals under 103 mental hygiene law, or developmental healthcare facilities. But controlled substances must still be one per blank. Prior to prescribing a controlled substance, you must check the New York State Prescription Monitoring Program, which just about all states now have. It's your duty to consult, requiring you to look at Schedule 2s, 3s, 4s, and 5s for the patients. You may check this up to 24 hours in advance, and you may check up to 30 patients at once. So you might have a nurse or somebody else that's a designee of yours look this system up and print it out the day before for you. There also may be medical marijuana on the listing itself. You'll see that. You must document that you checked the PMP. If you did not check the PMP, you have to document why you didn't check the PMP. There are exceptions that are listed in 8063, and that FAQ listing there is out. They list the exceptions in that too, and there's the HTML for you to look them up if you need to. A lot of practitioners will ask, why doesn't my controlled substance prescription that I prescribed previously show up on the PMP? I know I prescribed it, I looked it up, I gave it to the patient. Well, it could be the patient lost the prescription, maybe they never got it filled, maybe it was just too expensive or not covered by insurance, or maybe they got it filled out of New York State. There is ways on the PMP to check other states, like New Jersey and Texas and different states. If you want to do that, they recommend you check New York State first and then flag any other states that you want to look up. Otherwise, the system will run too slow. Why can't I find a patient that I know has a controlled substance filled? Well, it depends on how that information is entered into the system itself. So I use the example here, PAT, which can be a lot of variations to that. It could be a transmission error by the pharmacy. Pharmacists are required to transmit all controlled substance prescriptions at the end of the day to the Bureau of Narcotic Enforcement for the PMP. So any information in the PMP is not going to be longer than, I believe, it's 26 hours old. You know the pharmacy you transmitted electronic prescription to, so if it's not, if you don't see something correct, you can always call them and find out how that was entered. Nursing homes and hospitals, if a patient's receiving medication on the premises themselves, you do not have to check the PMP, but regulations require you to indicate that you did not have to check that PMP. So it's recommended you can use an abbreviation such as here, NPIP, which means I did not have to check the PMP for an institutionalized patient. Where the patient consumes the medication off premises, you have a duty to consult the PMP. That would be anybody who's on discharge or anybody who's going home for the weekend or whatever it may be. Patient records, you're required to maintain a patient record of all controlled substances administered, dispensed, or prescribed, and it must contain sufficient information to justify the diagnosis and warrant the treatment. So it might be blood tests, might be x-rays, and that type of thing. It has to contain at least the following information: any kind of patient identification data, their chief complaint, their present illness, the physical examination, and the diagnosis. Other data would support the diagnosis or treatment of what you're prescribing, and that would include any other test for the patient. The regimen, including the amount, the strength, and directions for use of the controlled substance. So if you're writing a written prescription, you could scan it into the patient's chart. If it's electronic, it should be in the patient's chart already. There's a 7-day supply rule, and actually there's a couple of the 7-day supply rules. You're not initially prescribed more than the 7-day supply of opioid medication for anybody with acute pain. Now, this does not apply to any chronic pain, but this would be somebody that, they just hurt their back or something initially, and just for an acute period of time, not more than the 7-day supply. And this is to help prevent any kind of opioid abuse or opioid addiction. And again, this does not apply to chronic pain such as cancer, hospice, end of life, things of that nature. Any subsequent consultations for the same pain, you may issue in accordance with existing rules and regulations. As pharmacists, we're not required to verify, but many pharmacists many times will do that if they see something coming from the emergency room, just to make you aware of that rule. In addition to the 7-day rule, no opioid shall be prescribed to a patient initiating or being maintained on an opioid treatment for pain, which has lasted more than 3 months or past the normal time of tissue healing. This is in section 3331, paragraph 8. Unless the medical record contains a written treatment plan that follows generally accepted professional or governmental guidelines. I included that in an upcoming slide. This does not apply to anybody with cancer that's not in remission or hospice end of life or palliative care. The treatment plan shall include, but is not limited to, the goals for pain management and functional improvement, discussion of how the opioid therapy will be tapered or lowering the dose, or tapered and discontinued if the benefits don't outweigh the risk. A review of the patient, with the patient, the risk and alternatives to opioids so they don't have abuse or addiction. An evaluation of risk factors for opioid-related harms. The documentation, as I mentioned, discussion shall be at a minimum of on an annual basis with the patient. An example of this is in the CDC Morbidity and Mortality Report, and there's a reference for you to look up. So let's talk specifically about electronic prescribing in New York State. This is the big one. So electronic prescribing, federal law states that electronic prescribing for controlled substances is optional. New York State was the first state to make it mandatory, so it's mandatory both for controlled and non-controlled substances, and this was back on March 27, 2016. So you should be aware you're probably already doing it right now. To sign a controlled substance prescription, the electronic prescription application must require the practitioner or the prescriber to authenticate it, and you do this 2 out of the 3 ways. And this is under federal law, HIPAA standards. Something that you know, like a password or response to a challenge question, okay? And make sure that you don't give your password to anybody else, any nurses or anything like that, because that's considered a felony. Something that you are, biometric data like a fingerprint or a scan. Some pharmacists use thumbprints. Something that the practitioner has, a device, a hard token, separate from the computer which you're gaining access. This would be something similar to when you're going to start a newer car, you just have that token in your pocket and you press a button, and that's the same thing. Everyone must have their system approved by the DEA, and the software shall be registered with the Bureau of Narcotic Enforcement. So the DEA has to approve that software. You'll get a certificate and you'll send that electronically off to the Bureau of Narcotic Enforcement, and there's the website and then what to do with it. Electronic prescriptions are created, recorded, transmitted by electronic means, obviously. This does not include faxing. It's issued and validated by the prescriber's electronic signature, so when you put this through, it'll ask you for that. They're electronically encrypted, so they can't be copied or altered in any way. And it's transmitted directly from you to the pharmacy itself. And that way we know it's legitimate. It's not email. You're not allowed to send anything. Now, they're talking about encrypted email with a password. That does not include that. Yeah, and ERXs are not faxing, like I said. You can't send anything by texting or social media or anything like that. This is strictly through a system that's made for this type of thing. Public Health Law 281, there are a number of exceptions to which you can issue an official New York State form, oral prescription, or fax, and these are all listed on references below on the bottom of the screen. You must indicate in the patient's health record when using one of these exceptions. Exceptions that are listed in public health law to electronic prescribing would be any kind of technological or electrical failure that you might have, so your system goes down. You might get an approved waiver, and there's different waivers that are out there. If you deem it impractical for the patient to obtain controlled substances by an electronic prescription, say you're out of town or you're at a relative's house and don't have access to the web, you can prescribe a quantity of controlled substance not to exceed a 5-day supply in paper or something, or by phone if you want to do that. To be dispensed by a pharmacy located outside the state, including federal institutions such as the VA, again, Indian reservations, or military sites. In addition to exceptions listed in the public health law, the Commissioner has included health blanket waivers that will be effective until March 24, 2020. And these are following circumstances that will allow a practitioner to issue a written official New York State or verbal for controlled or non-controlled. They're not required to indicate the circumstance on the prescription, whether it be written or verbal. And these are things like prescriptions with complicated directions, or directions longer than 140 characters, or compounded prescriptions with 2 or more products, or those that are infusion prescriptions that are compounded too. In addition, a prescription containing certain elements required by the Federal Food, Drug, Cosmetic Act, especially things like an attachment that you have to give to the patient, any kind of approved protocols for expedited partner therapy or collaborative drug agreement, or things like immunization or opioid antagonists, things like that, and a response to public health emergency that would allow a non-patient specific prescription also. They also include blanket waivers for vendors to nursing homes and residential healthcare facilities, and you're allowed to issue a written script or a verbal prescription for a controlled or non-controlled. And these are to be communicated to a pharmacist serving as a vendor for pharmaceutical services by an agent who's a healthcare practitioner for patients in nursing home and residential healthcare facilities. And you can find that in Public Health Law 2801. All pertinent information must be included: patient's demographic information, your information, drug information, if you're going to be doing it that way. E-prescriptions must include your signature, your digital signature, for us to accept it. It has to include your indication of either a brand or generic drug. This does not include over-the-counter medications or herbals. Your prescriber MPI number should be on the prescription, the e-prescription itself, since this is a federal requirement. And then one last note, any official New York State prescription that's handed to the patient with a notice that says electronically signed by the prescriber is not considered a legitimate prescription. This is not an electronic prescription by definition. Anything you hand to the patient must be signed by you because it's a legal document. This is an example of an electronic prescription that we see on our side that's being sent from you, with a lot of information on there, with your demographic information, your DEA, and so on and so forth, all the prescription information and the patient information. So we want to make sure they're exact as possible. Anything sent to us must be correct, otherwise our system will reject it. Written or e-prescriptions, all prescriptions for controlled substances must be filled within 30 days from the date it was issued by you, and no additional prescriptions or refills may be issued by a practitioner to an ultimate user for the same controlled substance. So in other words, a patient has to have a 7-day supply or less at home before you're allowed to prescribe more of that same control substance, same strength, and same directions. If your directions change and you have to submit that as a new prescription, always a good idea to contact the pharmacy to explain that circumstance, because the pharmacist may question it and call you. C2 anabolic steroids. Anabolic steroids are now C2s in New York State, even though they're federal C3s. It's a maximum of a 30-day supply, and no refills are allowed. C4 benzodiazepines are also a maximum of 30-day supply and no refills. C3s, C4s, which are non-benzodiazepines, and C5s are a maximum of 30-day supply, but they do allow 5 refills within 6 months if you so indicate that on the prescription itself. Federal law, the Federal Controlled Substance Act, states that a practitioner may issue 3 prescriptions for the same controlled substance at the same time to the patient. New York State does not allow this. New York State has what's known as condition codes. The condition or code must be indicated on the prescription itself. So you want to write for larger supply. So for instance, you have a child with ADHD, you want to give them a 90-day supply of Ritalin, so the mother can have some at home, the mother can take it to school and have some at the school. So they do allow these exception codes. You can provide up to a 3-month supply as determined by directions for use for substances for the treatment of these codes A through E. And again, the code or the condition must be on the prescription itself or indicated on the electronic prescription. Patients with panic disorders, that's code A. Attention deficit hyperactivity disorder is code B. Chronic debilitating neurological conditions characterized by a disorder exhibiting seizure or convulsions or spasms, that's code C. Relief of pain in patients suffering from diseases known to be chronic and or incurable, code D. And narcolepsy is code E. For anabolic steroids in the treatment for different conditions is listed there. You can prescribe up to a 6-month supply. Now, when I say up to a 3-month supply or up to a 6-month supply, it does not have to be a 3-month supply or a 6-month supply. It can be any variation thereof. So if you want to give the patient a 42-day supply or a 56-day supply, that's fine too. C2 anabolic steroids and benzodiazepines with a condition code, there's no refills on those. But C3, C4s, non-benzodiazepines, and C5s, you can indicate 1 refill if you want to do that. So you could actually give them a 3-month supply with 1 refill. Pharmacists are now required, as of October 22nd, to hand out a controlled substance information sheet to talk about the dangers of misuse and the potential for addiction. Pharmacists will go over all this information with the patient. They'll talk about physical and behavioral warning signs for addiction, available alcohol and drug addiction treatment resources, and proper disposal guidelines. And this is a sheet they'll actually hand to the patient and go over with them. Information must be provided in a language that is offered as English, as determined by the New York State Commissioner of Health, but that includes the 10 most commonly spoken languages from English in the state. So pharmacists actually have signs up there in patients' own language that tells them if the patient's not speaking English, and they can point to that, and then the pharmacist can help them out. Must be provided by patient electronically if requested by the patient, and that would be the October 22nd rule. Some common prescribers' errors that occur that we see from our side is you might be choosing the wrong patient, forgetting to shut one patient's profile down before prescribing to another. You might be choosing the wrong drug or the wrong strength. You might be using your own shortcuts, or they might be wrong shortcuts or misspelled. Letting office personnel use the electronic prescribing software. If you do that, please make sure you verify everything and put in your own password. Turning off safety features of the system. So it might have this alert that keeps coming up and you want to just turn it off. Many of those alerts can't be individually turned off. Many of it's group alerts, so you have to be careful with that. Things like look-alike drug names or choosing the names instead of choosing the lab names instead of the drug names. Not keeping data systems up to date. Prescriber fatigue with the system. There's too much information there that you're being required to do. Being interrupted while e-prescribing. Thank you for taking the time to view this lecture on controlled substance prescribing for New York State. Questions about controlled substance prescribers can be directed to the Bureau of Narcotic Enforcement at the website below. Thank you again, and have a great day.
Welcome to the Opioid Prescriber Training Program as required by the New York State Department of Health. I'm Dr. Wagbury, and I'm here to present this section of the mandatory opioid training course. The objective of this course is to describe the pathophysiology and general approaches for pain assessment in the ambulatory setting. We will also describe approaches for managing acute pain and how they differ from approaches for managing chronic pain, which are distinctly different. We'll also outline the clinical guidelines currently approved for appropriate prescribing of opioid analgesics in both groups. In order to proceed further, we have to understand what pain is. Pain, essentially, as defined by the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. To differentiate the concepts of acute from chronic pain, we have to understand that acute pain is pain that arises from disease, trauma, or other causes, and that's usually time-limited, and it's recent in onset. It basically serves a very useful protective biological purpose or role. Chronic pain, on the other hand, is distinctly different. This is described as ongoing or recurrent pain, lasting beyond the usual course of the acute illness or injury that produced the acute pain. Typically, by definition, the time frame that's accepted is between 3 to 6 months, and this does vary. And it usually adversely affects the patient's well-being. So pain that continues when it shouldn't continue is regarded as chronic pain, or pain that is there beyond the healing process is becoming or determined as being chronic pain. When we look at the chronic pain pathways, we have the ascending pathways. Typically, impulses or noxious stimuli from the periphery enter through the dorsal horn of the spinal cord. They synapse at the wide dynamic range interneurons and get transmitted up to the brain via the hypothalamic region, where it ends in 3 areas in the brain: the somatosensory cortex, the cingulate gyrus, and the frontal cortex. The brain, on the other hand, does try to modulate these noxious impulses from the periphery and sends negative inhibitory impulses down to try and minimize the impact of the sensitization at the wide dynamic range interneuron, while in the periphery, where the noxious stimulation occurred, there's an attempt to heal that area by virtue of the infiltration of inflammatory processes in cells that attempts to repair the tissues that were injured during the event. In terms of categorizing pain, it's important to understand what elements of pain are important that will ultimately drive your therapeutic options. We can categorize it by severity, where it can be mild, moderate, and severe, and this is typically based on the numeric pain score, which we all know is highly subjective, so using this only as a distinction is somewhat inappropriate. We can also look at the pathophysiology, where we're looking at nociceptive pain versus neuropathic versus mixed. Most chronic pain states, if not all, are mixed pain states. They have elements of neuropathic and elements of nociceptive pain. We can also look at disease origin, if it's cancer or non-cancer. Cancer pain is treated and viewed on very, very differently from non-cancer pain. We can also look at temporal relationships. Again, is it acute? Is it chronic? And if it is chronic, is it persistent chronic? Does it have intermittent episodes of chronicity? Or does it have persistent baseline chronic pain with episodes of what's called breakthrough pain or exacerbated pain? That breakthrough pain tends to be incident-related in the majority of cases. So it's something the patient did to cause that increased episode of exacerbation in the patient's overall pain. Looking at the chronic pain states, which I mentioned is mixed, most of the mixed pain we see is present in chronic pain. Some examples right here on this slide is low back pain with elements of radiculopathy. It may even not have radiculopathy. Cervical radiculopathy, cancer pain can be the same, and of course carpal tunnel syndrome. This list is by no means exclusive. And if you look at strict neuropathic pain, postherpetic neuralgia is a very good example of that, trigeminal neuralgia, painful diabetic neuropathy, post-surgical neuropathic pain. Examples of that are ilioinguinal herniorrhaphy with subsequent ilioinguinal neuralgia, post-cholecystectomy pain, where the patient has neuromas at the trocar sites in the belly that can produce neuropathic pain. Post-traumatic neuropathy of any cause, these are good examples. This pain is typically burning, tingling. The patient may be hypersensitive in certain areas and may be sensitive to touch or heat or both, or even cold. Nociceptive pain, by definition, is pain that is due to inflammation, localized. So limb pain after a fracture, joint pain after osteoarthritis, postoperative visceral pain. This tends to be an aching, deep-seated pain. It may have sharp episodes and tends to be throbbing in nature. We do have a problem because the knowledge that physicians currently have on pain management is somewhat limited. And it's limited in a multifactorial basis. There's failure to use the multimodal approach. Patient walks in, the first thing they get is a prescription, instead of getting a history as to, have you tried physical therapy, have you tried a TENS unit, have you tried all the other modes that are available to try and interrupt these pain pathways. So you miss the benefits of physical and behavioral and psychological approaches to train the nervous system. And it's important to consider these even before you start talking about scripts. Failure to target the mechanism of pain. This really is on the basis of not or lacking an understanding on the physiological concepts and the structural differentiation of pain, as I've mentioned in a previous slide. If you don't treat acute pain appropriately, data shows that the likelihood of chronicity is increased. So good treatment of acute pain will decrease the likelihood of developing a chronicity. Failure to treat neuropathic pain with adjuvant medications. So someone comes in with neuropathic pain and the first thing they get is an opioid medication is probably inappropriate. There are many adjuvant medications that can be used quite successfully, either alone or in combination with a low-dose opioid that can be very successful in treating these pain states. Also, heavy use of short-acting opioids instead of long-acting opioids is problematic in itself, as the long-term use of short-acting opioids gives you this typical sawtooth phenomenon when you look at PK data on the particular drug, and that is not beneficial to a patient long-term because they do develop opioid tolerance somewhat quicker. And also the use of Tylenol, or acetaminophen, as I've put it in the slide. Toxicity from acetaminophen is a growing concern in the USA due to liver issues. So in order to treat pain appropriately, you need to do a baseline patient assessment. A definite comprehensive pain evaluation should be performed. So there should be a physical exam, a clinical history, which includes the pain history, the medical history, and the psychosocial history. You have to look at the laboratory and diagnostic elements that were submitted for that evaluation. And please examine the patient, most important. A lot of what you will learn when you do a baseline assessment is from the history. Your exam simply confirms or looks for new elements that might help you confirm what you are thinking of. Determine the underlying mechanism, because that will determine the elements you are going to pull in the overall comprehensive care of the patient. Categorize the pain by quality, site, and severity. And look at all the treatments the patient has tried before and document success or failure. This mnemonic, the PQRST-U, is a helpful tool in assessing pain symptoms. The P stands for precipitating or palliative events, including medications. The quality of the pain, burning, electric-like, dull, stabbing, tingling, etc. The region of radiation. Does it follow a mononeurotome? Does it follow a dermatome? Is it a complex neurotome distribution? Where is it? Periphery, proximally, etc. The severity. Severity uses the pain scales. And remember, I mentioned earlier, severity alone does not determine whether something needs to be treated with an opioid or not. The timing or temporal relationship. When does it start? When does it happen during the day? What are you doing when it happens during the day? The pattern and the duration. How long does it last when it does occur? And the U stands for the U. How are you affected by this pain? What impact does it have on your function and your day-to-day living in terms of your quality of life? Because that also determines whether you're going to treat it with an opioid or not, or other modalities as you see fit. An example of this is someone who comes to you in a wheelchair that says, I have back pain, and you prescribe an opioid, and the patient is still in the wheelchair having the same back pain, and you ask the patient, what have you been able to do since you prescribed the opioid, and they say, stay in the wheelchair the whole day, you probably had no business writing the opioid in the first place. When you do the evaluation, you have to evaluate the pain severity. So on every visit, you document the current pain level, the worst pain in the last 7 days, and what's the average pain been in the last 7 days. For this, you can use the numeric pain scale. You can use the FACES pain rating scale. This is not appropriate for adults, they're mainly for children. You can use the PQRSTU mnemonic that I gave you and the McGill Pain Questionnaire. There are also some scales for special populations, and I can refer you to the websites that we've listed on the slide if you'd like to explore those options further. This is just illustration of the simple descriptive pain intensity scale. The one that is most commonly used is the middle one, which is the 0 to 10. Actually, it should be an 11-point numeric pain scale, because the 0 counts as 1 and the 10 counts as 1. That's the one that's most commonly used in chronic pain practices. Looking further with regard to patient evaluation and risk assessment, prior to prescribing any opioid, it's important for you not only to do the detailed history, but to assess the patient's risk. It's a stratification that determines what risk level this patient that you are currently evaluating is placed at. This will determine what you may or may not do with regards to treatment. Risk assessment is done for potential opioid misuse and abuse. And there are many initial screening tools available to identify those at risk for aberrant behaviors and substance use disorders. Based on the risk level, the tools allow you to prescribe or tailor your treatment plan accordingly. And I would feel that this is really an important tool to do on every patient that you're considering prescribing opioids. I would also hasten to add, even if you're not considering prescribing opioids, that this assessment be in your evaluation so that it will serve as a protocol for future times when you may be called upon to treat the patient with an opioid. So risk assessment, you can use the DIRE score, D-I-R-E. The D stands for diagnosis, the I stands for intractability, R stands for the risk. The risk includes psychosocial, chemical health, reliability, and social support. And then E is the efficacy score. Mitigation strategies to prevent abuse and addiction. A prevention protocol is extremely important. Why? Because it helps prescribers monitor adherence to the medications you're prescribing and to minimize the possibility of diversion. In this regard, an opioid treatment agreement or a pain care treatment agreement is important. I would hasten to add that any medication agreement is important. And this basically spells out the rules of play. There are many that are available on the website, and there are some websites you can go to download some and modify them to suit your practice needs. Routine and random testing should include urine testing, which helps you to determine compliance with your prescriptions, as well as checking the prescription monitoring database, the iStop, within a 24-hour period prior to prescribing the opioid. Random pill counts are another important tool that helps you determine if the patient is in fact using your medications as you have prescribed. And this is truly random. You don't determine this week that the patient will come in next week and inform the patient. The patient should be told, per your medication agreement, that they could be called in within a certain time frame, and they have to bring all their pill bottles and pills with them for a count in your office. And this is extremely important. The COM17 is a current opioid misuse measurement tool that is important when patients are on opioids and are using them. It will help you determine, based on a risk factor, which is scored, what is the risk of the patient misusing the medication. Routine patient assessments are extremely important to determine continuation of the opioid you have prescribed for the patient. Examples of opioid consents and agreements can be found at these following websites. You could always download them. I think they are free, and you could modify them to your needs to fit your individual practice needs. Talking about routine and random urine testing, the purpose is to identify drug misuse, abuse, and diversion. So the urine drug tests are an extremely important tool in this regard. Prescription drug monitoring program is also important, as that helps you determine if the patient's using the medication as you have prescribed. When we look at urine drug testing, there are random screens versus scheduled screens. So the scheduled screen, every new patient should have a urine screen. The random can be done at a visit, or the patients can be called in randomly for a urine screen. I would suggest that the patient's called in randomly for a pill count and a urine screen to be done at the same time. It seems to be more convenient. In terms of how frequently you test urine screens, this very often is driven by the carrier that's paying for the urine screens. In someone who is low risk, 1 to 2 times a year is adequate. Someone who's high risk, I would suggest you can treat as many times as you want, but please do look at the payer's approvals with regard to that. Know the laboratory, because you need to know what their values in the result sheets mean. Also look at opioid metabolites. Just knowing that it's there or not there is not adequate. There are variations in opioid metabolism based on genetic variation that determines the type of metabolite that's produced and whether indeed the patient metabolizes the opioid appropriately. Look at the creatinine concentration. Patients can tamper with their urines, especially if the urine collection is unobserved. So you need to be aware of the creatinine concentration. And then how do you interpret this data? If you don't have basic knowledge on the different metabolites and the molecules and how they're metabolized, your interpretation can be flawed. So I would argue that speak to the toxicologist at the urine lab, who are always there to help you out with interpretation of the data. If you do a point of care testing, which is simply a litmus test, either there's an opioid there or not, by the change of the color in the litmus paper or the strip that's in the cup, that needs to be sent out to the lab for confirmation, especially if it shows positive for any elements that shouldn't be there, including any elements that should be there, for instance, the prescription you're writing, because you need to know that what you're prescribing is consistent with what is being found in the urine. And a good confirmation laboratory will issue data saying that this amount that we've seen in the urine is consistent with the prescribing that the patient is currently on, or the prescription that you have prescribed. Briefly about the COM17, I think it should be a routine risk assessment for ongoing treatment to screen patients for drug misuse. It's used to supplement your physical exam. So this assessment on its own is not to be taken on face value. Without a physical exam, a patient review or interview, and a clinical assessment as to whether your opioids or your treatment plan is working for the patient. It's a simple test of 17 questions, as the name says, and it basically helps you identify any misuse. And I can refer you to the website for further evaluation of how to score it and how do you interpret that data. Let's talk about acute pain briefly. Acute or nociceptive pain is the result of an injury or illness that is expected to be time limited, and it's characteristic of a recent onset. It's divided into 2 types: somatic, which is typically a constant aching, gnawing, throbbing, well-localized pain, typically seen in bone, joints, muscle, skin, or connective tissue. And then you have visceral pain, which is usually visceral, produced in organs. It's poorly localized, deep and intermittent cramping in nature. Acute pain is a protective response to a noxious stimulus. So it allows organisms to live in an environment that is full of potential dangers. Characteristics of acute pain. Duration is short. Generally, the pain resolves within days or weeks, or when the inciting event is no longer present. Pain is usually present for less than 12 weeks. Therefore, any pain that's present longer than 12 weeks is to be considered as chronic pain. Now, there's a bit of variation here, because surgical pain can be shorter than 12 weeks, it can be shorter than 2 weeks. So any pain that exists beyond the expected healing from the surgical procedure that you cannot explain based on what prompted the surgery can be considered chronic. So there is a little bit of variation in the definition. Pain of varying intensity is acute pain. It subsides with healing. So you expect the initial acute pain rating to be high, and as healing takes place, the pain rating should drop over the time frame. The nervous system is usually intact. Apart from the excitation of the C nociceptive fibers in the periphery, the rest of the nervous system is still functioning on a normal basis. The reasons for pain can usually be identified: trauma, surgery, acute medical conditions, or physiological processes. And it responds well to non-pharmacological treatments or, I should say, non-opioid analgesics. Psychological problems may not typically be associated, although sometimes it can be. And if it is, for example, depression, it's usually short-lived as the pain decreases and as the healing process proceeds. So how do you manage acute pain? Opioids are not the first treatment for acute pain. That's in someone who sees you for acute pain, not a surgical acute pain episode. That may require opioids, and we can talk about that. Opioids should be reserved for acute pain where alternative treatments are ineffective or contraindicated, or where acute pain results in severe restriction of ability to function on a day-to-day basis. Typically, the purpose of an opioid is to control the pain so the patient can return to function. And if the patient's not able to function because of acute pain, that's a reasonable basis to prescribe an opioid. Initially, initiate treatment with non-opioid analgesics in combination with non-pharmacological therapies. And opioids should be tapered and discontinued as the acute pain improves and resolves over that time frame that you expect it to, like in postoperative pain. So the mechanisms of action of opioid analgesics. Opioids bind to opioid receptors within the CNS and peripheral tissues. We have mu-opioid receptors, which are supraspinal, and they produce analgesia supraspinally. They are responsible for respiratory depression, euphoria, sedation. They decrease GI motility, promoting possibly constipation, and they have a tendency to create physical dependence. The kappa receptors are responsible for spinal analgesia. They can also produce sedation, dyspnea, dependency, dysphoria, and also respiratory depression. The delta receptors may be responsible for some of the psychomimetic and dysphoric effects of opioids, and the sigma receptors are predominantly responsible for psychomimetic effects, dysphoria, stress-induced depression, but they're no longer considered as an opioid receptor. Let's look at some examples of pure opioid agonists. So we have morphine, codeine, hydrocodone, oxycodone, hydromorphone, oxymorphone, methadone, meperidine, fentanyl, and levophonol. Clinical considerations. These agonists have high binding affinity to the receptors, particularly the mu-opioid receptor. They have no analgesic dose ceiling effect. The degree of analgesia is limited only by the side effects, which may be tolerable or intolerable. Typically, if you increase the dose, the likelihood of analgesia increases, but also the side effect profile increases. Other opioids, such as tramadol and tapentadol, these are weak agonists at the mu-opioid receptor. Both of these can work in neuropathic pain simply because tramadol inhibits the uptake of norepinephrine and serotonin, and tapentadol inhibits reuptake of norepinephrine. And keep in mind, the negative inhibitory pathways both use serotonin and norepinephrine as their neurotransmitters. So these work not only on the mu-opioid receptors, but also on these negative inhibitory pathways. So they have a dual mechanism in one tablet. This is a busy slide, and I've put it here just to assist you in thinking about how these medications work and what their metabolites do in terms of special considerations. So if you look at morphine, the active metabolite is M6G, morphine 6-glucuronide, which may accumulate in patients who have renal impairment and may accumulate to toxic levels in patients who have renal impairment. So a lot of the boxed warning surrounding patients who have borderline renal function will stipulate that you have to start at very low doses and very infrequent dosing until you can assess the effects of this medication in that patient due to the somewhat affected renal function. Codeine is a weak analgesic, more effective when you combine it with acetaminophen, and it's metabolized to morphine. Again, knowing the metabolites is extremely important when you use some of these medications. Hydrocodone is metabolized to hydromorphone, that's its active metabolite. Hydromorphone may need to be dose adjusted in patients with renal and hepatic impairment. Oxycodone can be used either alone or in combination with acetaminophen, and dose adjustments are required in patients with renal and hepatic impairment. Oxymorphone, on the other hand, has to be taken at least 1 hour before or 2 hours after a meal. Tapentadol, as I've mentioned, Has a dual action. It works not only on opioid receptors, but also works on serotonin pathways and norepinephrine pathways, and therefore you have a dual action in one tablet. Tramadol can be used alone or with acetaminophen. It does have a serotonin action as well as an opioid effect. It's the metabolite that has the strong opioid effect and should be used with caution in patients taking any medications that affect serotonin levels. Drug interactions with opioids. Pharmacokinetic interactions do occur, and depending on the metabolic pathway, whether it uses cytochrome P450 or glycoprotein, whether the patient is using any glycoprotein inhibitors or inducers, that can affect the drug levels of the ultimate metabolites as well as the parent drug. Alcohol in combined or combination with opioids is not a good idea, as this affects both pharmacokinetic and pharmacodynamic effects of the drug in the plasma. And there are specific drug-to-drug interactions, such as the concurrent use of CNS depressants, such as benzodiazepines and alcohol, which can produce additional depressant effects when used in combination in the same patient. Agents with serotonin activity, as I mentioned, and monoamine oxidase inhibitors, which is a potent serotonin-type medication, can be problematic and can precipitate serotonin syndrome and should be used with caution in such patients. So in this particular slide, this is an example of some equianalgesic dosing conversion charts that would assist you in converting from one particular opioid molecule to another opioid molecule in instances where the first opioid that has been prescribed is ineffective, or in instances where you want to do an opioid rotation. Based on patient variability, it is recommended that when the conversion is established in terms of the numerical conversion dose, that one starts between 25 to 30% lower than the calculated dose. I would like to touch briefly on the morphine milligram equivalence, which is part of the CDC guide and is now forming the basis of any decision to prescribe opioids in terms of how we calculate what dose the patient's on. So the recommendation is currently doses above 50 MMEs per day increases the overdose risk by 2 times of doses less than 20 MMEs per day. So if you have a patient that you are above the 50 MMEs per day, you need to monitor these patients frequently, discuss reducing or tapering their opioids if they don't meet certain criteria that you have established, i.e. functional goals as well as pain reduction, and consider these patients to be at high risk and provide them with naloxone, which they can keep in their armamentarium. Any adjustments higher than 50 MMEs, up to 90 MMEs and higher, should be very carefully monitored and very, very appropriately justified. If you cannot justify higher doses, then you probably have no reason to prescribe higher. So there are certain tools to calculate the MME, and I would refer you to both the CDC as well as the second website, which is globalpharmacy.com. And that could give you more information on the MMEs and how to calculate them. When one prescribes opioids, it's important to understand that there are side effects with all opioids that can be prescribed. And these side effects are listed over here. Gastrointestinal, where constipation is the biggest issue, nausea is the second. You may have a patient who's constipated on low dose when you first started it. You may have one that's constipated at higher doses. Constipation is not totally dose dependent in every patient. If you don't ask the patient about their bowel motions, they will not routinely tell you they're constipated. This is not a pleasant conversation in a doctor's office. So you do need to ask the patient. So it's important to know what their normal bowel motions were prior to the initiation of an opioid, and then you ask them, how has it been since they've been on the opioid? And that'll tell you if they're constipated. There are central nervous system side effects such as drowsiness, dizziness, sedation, hyperalgesia, and mood changes. To touch base on hyperalgesia, patient comes in and says the current medication dose is not working, the pain is still bad. You examine the patient to determine, yes, the pain is bad. You raise the dose and the pain gets worse or is the same. That is suspicion of opioid hyperalgesia. The proper treatment is to wean the patient off the opioid. Bladder dysfunction can occur. Urinary retention is a big problem. Again, ask the patient, but most patients will tell you because having a distended bladder is not very comfortable. There are cardiovascular side effects such as hypotension, bradycardia, and QTc prolongation. Respiratory depression is the most severe side effect, that is the most disturbing side effect, and hence you need to monitor these patients. When someone comes in with respiratory problems or obstructive sleep apnea, you have to be highly cautious when you prescribe an opioid. Pruritus can occur. It's due to histamine release and can be treated with an antihistamine. In some situations, it is not totally responsive, and you may have to wean the patient down. A dry mouth is a problem, not totally bothersome. We just encourage patients to drink lots of fluids and keep their mouths relatively moist. Sweating can occur. Again, not very frequently. It is problematic in certain patients. And sexual dysfunction is quite common in a lot of patients who are taking opioids. How do you manage these side effects? Well, you can use antiemetics, particularly if it's nausea, and you can use various bowel regimens as well as various medications to treat constipation. Diet modification is also important when you treat constipation, so that's simple things the patient can start prior to writing a prescription for constipation. Many adverse events or effects will spontaneously resolve with continued administration and as the patient continues to use the opioid and develop some element of tolerance with the medication. The only exception where this does not resolve is constipation. So you may need to treat that appropriately if required. If you always start low and go slow, you will minimize the side effects, and also you'll be able to determine the dose which is most effective for the patient. Always try to start at the lowest possible dose and titrate to the effect you're looking for. How do you manage the constipation? Well, there's various ways. One is diet. I've spoken about that. Softening agents have little value when used alone, although in some patients that may be effective. Stimulants such as senna, which is the mainstay of therapy, can be used and initiated. Those are very simple, that can be done quite easily. And the osmotics such as lactulose, sorbitol, can be added as stimulants. You have saline products such as with magnesium citrate, magnesium hydroxide. These are the cathartics that will relieve, and then once the constipation is relieved, you adjust the doses accordingly. Then you also have the pamoras, or the peripherally acting mu-opioid receptor antagonists, such as naloxegol, methyl-naltrexone, and melamine, which can also be prescribed. However, most of the time you would start with the very simple remedies first, and if those are successful, maintain those. If not, then go on to a prescription medication. And you could also use mineral oil as a lubricant in these patients as well. So let's briefly touch on acute pain management and the role of opioids in acute pain. First-line treatment, as I mentioned before, is not to use an opioid. It is non-pharmacologic plus a non-opioid analgesic, such as acetaminophen and non-steroidal anti-inflammatory agents, with an adjuvant of some nature, which we'll talk about later. Prescribe at the lowest effective dose of an immediate release opioid if you do need to add an opioid to that. So if these first-line options are ineffective, then it is reasonable to prescribe an opioid, but always prescribe the lowest dose that's effective. Combine this with non-pharmacologic and non-opioid alternatives to improve function and pain. So it's not, if the first line doesn't work, stop those and introduce an opioid. No, if the first line doesn't work, then add an opioid at the lowest possible dose. Do not prescribe opioids for longer than is deemed necessary or appropriate for that acute pain condition that you're treating. Patients who are given opioids for acute pain are at a higher risk of using opioids long-term, particularly when the doses haven't been prescribed appropriately or adjusted accordingly based on the decreasing pain that is expected from an acute episode that produced the pain. Also, a patient should be appropriately monitored and evaluated. Keep in mind, acute pain patients tend to be opioid naive, and therefore, if you prescribe an opioid, they're at a higher risk for respiratory depression, and hence should be appropriately monitored and evaluated. The current guideline says that you rarely require an acute pain opioid for more than 7 days. And in fact, in the post-surgical acute pain arena, 3 to 5 days is adequate, and patients should be reevaluated to determine if they still need to continue on an opioid beyond that time frame. So a reevaluation, as I mentioned, is needed if the pain persists beyond the time frame of 3 to 5 days, which includes post-surgical pain. Extended release formulations are not to be prescribed for initial management of acute pain. The patient should be educated about the potential risks and side effects of using the opioid, and avoid prescribing opioids in combinations with other CNS depressants such as benzodiazepine, sedative hypnotics, or skeletal muscle relaxants, as the risk is more when these medications are used in combination. If there has been no improvement in the pain and or function or the quality of life, then maintenance of the opioid is not appropriate. The patient should be considered for discontinuation or weaning off the opioid in consideration of other modalities. What are the pharmacologic treatment options? Acetaminophen, as mentioned. Non-steroidal anti-inflammatories, the examples are listed there. COX-2 inhibitors can also be an option. Full opioid agonists, only if the combinations of the opioid with acetaminophen are not totally effective or insufficient to control the level of pain that the patient experiences. And if you use tramadol, it's less effective than hydrocodone acetaminophen, and can be used as both a first-line and a second-line medication in patients who have acute pain. In chronic non-cancer pain, how do we classify that? Well, most of these patients have neuropathic pain. So here you're treating neuropathic pain. So the first line is pharmacological treatment options. We have the alpha-2 delta ligands, such as pregabalin and gabapentin, which are indicated and used for neuropathic pain states. We also have the SNRIs, the serotonin norepinephrine reuptake inhibitors, that can also be used quite effectively, as well as the tricyclic antidepressants. Second-line treatments include the topical agents, such as lidocaine and capsaicin, that can be quite effective in the neuropathic pain states in patients who have cancer-related pain. In chronic non-cancer pain, this can be classified based on various components that are contributory to the pain, such as musculoskeletal pain. By definition, this is pain caused by a lesion or disease of the musculoskeletal system, which includes the muscles, the ligaments, the tendons, the cartilaginous structures and joints. Commonly involves regional areas such as the neck, shoulders, trunk, arms, low back, hips, and lower extremities. In the description, there's tender muscle sites. Pain is usually referred from one particular area that's exquisitely painful. These are called trigger points. The cause is usually an injury or a repetitive occupational activity, or in fact a fracture, an obstruction, a dislocation, or a compression of a tissue by a tumor, cyst, or bony structure that has resulted in this muscle injury that's causing musculoskeletal pain. First-line pharmacologic treatment options include acetaminophen, non-steroidal anti-inflammatories, as well as the topical agents. Keep in mind that also first-line is stretch, massage, physical therapy. These are to be used adjuvantly or along with your current medication treatments. Inflammatory pain can also occur, and this is pain caused by inflammatory processes such as infection, which can be autoimmune as well. It's generally associated with the infiltration of immune cells and tissue damage in the area where the pain is occurring. Progressive pain that is sharp, it's described as sharp, lancinating, with or without increased pain with movement. The pain site may be tender, hot, and red, with swelling at the site, and also with a history of injury or some elements of inflammation that has been known to the patient. Rheumatoid arthritis has very special recommendations, and some other conditions in that element of the arthritides have some special recommendations that you can refer to. But the first-line pharmacological treatments for patients who have inflammatory pain are NSAIDs, once again, and glucocorticoids, as well as topical agents. The first-line treatment options, which would include non-pharmacologic, as I mentioned before, physical therapy, acupuncture, massage, behavioral therapy, and cognitive therapy. These are all elements that should be incorporated prior to considering medications or, in fact, even indeed opioids. The concept of multimodal analgesic approach is extremely important because some patients might do very well with a non-medication treatment. So this is the use of multiple methods that can be used either combined or concurrently to decrease the amount of medications or in fact obviate the need for medications to relieve pain. It can also be used in patients who are using medications to minimize adverse drug reactions by allowing you to use much lower doses. Most patients will benefit from a multimodal approach, should always be considered when you're dealing with chronic non-cancer pain. And using these multimodal techniques, as I mentioned, they have opioid sparing effects, allowing you to use much lower doses of opioids. The current consensus guidelines do support this approach as part of your management of pain. With regards to reassessment, patients started on non-pharmacologic and or non-opioid analgesic therapies for chronic non-cancer pain should be reassessed for improvement. It says every 2 to 4 weeks. Again, it depends on your practice, but certainly minimum every 4 weeks, they should be evaluated to determine efficacy and the need for further interventional or modalities that need to be initiated. So when does one initiate short-acting opioids? Patients who have pain severe enough to require an opioid analgesic, despite an adequate trial of non-pharmacologic and non-opioid therapies, should be evaluated to determine if a short-term trial of a short-acting opioid is appropriate. They should be educated that they are not to expect pain relief or total pain relief with opioids. Studies have shown that if pain improves by an average of 2 to 3 points over their baseline, lower than their baseline, then it is reasonable to continue the short-acting opioid or to prescribe an opioid with the intent to switch them to a long-acting opioid if they need this on a long-term basis. All patients who have never used opioids before are determined to be opioid naive and therefore are at a higher risk for respiratory depression when you initiate an opioid. Hence, always start at the lowest dose in someone who's opioid naive. Do not escalate doses frequently, but do them at intervals of a week or 2 weeks out and evaluate each dose with regards to efficacy to determine if an increase in dose is warranted or not. So the routine assessment during the treatment. Continue the opioids after you have seen clinically meaningful improvement in pain and function without any risk or harm. Your reassessment has to include the 4 A's: the amount of analgesia the patient's getting, the activity level of the patient, the function of the patient, the evaluation of risk and aberrant behaviors, and the evaluation of whether any of the medications are causing any adverse effects. If a dose increase is warranted, or if you have increased the dose at the last visit, the patient has to be reassessed within 1 to 4 weeks. For continued therapy, you have to assess benefits versus harms at a minimum of every 3 months. Optimize the non-opioid therapies. Keep in mind, just because a patient is doing well with an opioid doesn't mean you abandon any of the other non-opioid therapies. These have to be concurrently introduced and continued by the patient, even if it's something as simple as doing a home stretching exercise program, doing yoga, doing hypnotherapy. They have to be engaged and vested in the overall well-being. Determine also whether you need to continue, taper, or stop the opioids when the end results are not met or when the opioid is no longer needed. That there's a checklist for prescribing an opioid long-term. Set realistic goals for function and pain. Verify the use of non-opioids first. Have they tried all these non-opioid medications? Discuss the risks and benefits with the patient, such as overdose and addiction. Evaluate the risk of harm or misuse. So look at your risk factors, your risk stratification. Check the prescription monitoring database and do a urine screen. Then also establish criteria as to when you will stop or wean or discontinue opioids. Assess baseline pain and function at the initial assessment and then after you've introduced an opioid at subsequent assessments while the patient's on opioids. Prescribe a short-acting opioid initially in an opioid-naive patient at the lowest effective dose and reassess, and if it is determined this patient will need this opioid long-term, then some sort of interest should be established with introducing a long-acting opioid and decreasing the number of pills of the short-acting opioid that are used per day. There are certain FDA boxed warnings for opioids. The risk of addiction, abuse, and misuse may lead to overdose and death. So assessment of risk factors before prescribing an opioid and monitoring for the development of addictive behavior is extremely important. There are serious life-threatening or fatal respiratory depression that can occur with the use of opioids alone and in combination with other medications. Accidental ingestion is a problem, especially in children, and can result in fatal overdose. And you could add in their pets as well. I do require that most patients keep any opioids locked in a cabinet or in a lockbox in an area where the kids cannot get to. Prolonged use of opioids during pregnancy can result in neonatal opioid withdrawal syndrome. And if the patient has been using opioids during pregnancy, then the neonatologist or pediatrician present at the delivery should be alerted to the fact that the neonate or the newborn would present with features of opioid withdrawal syndrome. I mentioned combination with benzodiazepines, which increases the risk of respiratory depression and death, but in this you could also add alcohol and other CNS depressants. If the patient is having inadequate pain relief, what options do you have? Well, you can certainly do a dosage titration. Slowly raise the dose to minimize toxicity to establish a dose that has the effect that you're looking for, with the satisfactory balance between dose and benefits, and then potential adverse events and harm. You could do an opioid rotation or switch the opioid. This may help improve efficacy with reduction in side effects. And it may allow you to start at a lower dose. And we mentioned the recommendation of 25 to 30% lower than the conversion dose that you've calculated. The addition or optimization of non-opioid adjunctive agents may be another option without touching the opioid. See if you need to modify it. Maybe you need to add another modality in to see if that helps. And the other option is to discontinue the opioid. If a patient comes in and says the medication you're currently prescribed is not working at the dose and you do not desire to increase the dose, an option may be to discontinue or wean off the opioid. With regard to long-acting opioids, there are certain advantages. Long-acting opioids can achieve more consistent control of pain with fewer daily doses. It may improve adherence too. Taking 2 pills a day as opposed to taking 4 pills a day is better for a patient. They prefer that. You may consider this in patients who are taking a short-acting opioid for less than 90 days. So someone who you've initiated a short-acting opioid that you now anticipate is going to be needing an opioid on a long-term basis should always be considered for the addition of a long-acting opioid and a reduction in the short-acting opioid use. Do not exceed 90 days with the use of a short-acting opioid on a daily basis. Patients should never be given more than 1 long-acting opioid at a time. So 1 long-acting opioid with 1 short-acting opioid, where the short-acting opioid dosing units per day is reduced. And we will talk about an example at the end of the deck. Abuse-deterrent opioids are available. Given the current environment, we now have the ability to prescribe these opioids. Most of these opioids have been tested thoroughly, and in some of them, they resist in vitro manipulation and extraction studies in the laboratory. They are quite robust pharmacokinetic studies to show what happens to the PK when these medications are modified or manipulated. They have also included some clinical abuse potential studies, and there's post-marketing data which hopefully will come out the more we prescribe these medications. There are different categories which they look at with regard to these abuse-deterrent opioids. There's physical chemical barriers as how they are made, what sort of elements in the design make it difficult for these products to be misused or abused or manipulated. Some have agonist-antagonist combinations built into them. Some have aversion, which means if you use them in a manner they're not designed to be used, they're highly irritant. Some have a delivery system that's modified so that if you do try to manipulate it, the delivery system is affected and you will not get a plasma level that you would achieve if you used the medication as it has been designed to be used. Some have totally new molecules with prodrugs. Some have combinations of what I've mentioned above, and some have novel approaches to the medications. Here are some examples of abuse-deterrent opioids. OxyContin, one of the first ones, or extended-release tablets, came in April 2010. Embeda, which has the naltrexone sequestrated in the inner core, August 2009. Just to mention briefly, that naltrexone is only released if the embedder is crushed and manipulated. Hysingla ER, which is hydrocodone extended-release tablets, has what's called the hydrogel technology, which means if you crush it and try to mix it and take it and snort it, it'll form a hydrogelatinous gel. And if you try to inject it, it'll simply block the syringe needle, meaning you will not get the full amount that you want to get. Morphobond ER, which is a morphine preparation, consists of 3 layers of abuse-deterrent technologies. Xtamza ER, which is oxycodone, extended-release capsules. Arimo ER, which is a morphine extended-release tablet. And Roxybond, which is oxycodone tablets, currently not released as yet. Hopefully will be released next year. Discontinuation of opioid therapy may be recommended due to severe and unmanageable side effects. That goes without saying. If you've put a patient on an opioid and they're having side effects that you cannot manage, you're going to stop it. So you're not going to recommend to stop it, you will stop it. The patient will make you stop it. Serious non-adherence to treatment plan or unsafe behaviors is an indication to immediately address the issue, and then what you do is based on what dose the patient's on. If the patient's on a very high dose of an opioid and they've shown that the opioid and the metabolites are in the urine, immediate discontinuation of the opioid is not appropriate because we will put the patient straight into withdrawal. So a correct way is to decrease the dose, address the deviant behavior with either yourself in the office or a referral to an addictionologist or a risk assessment psychologist who can help you. If the patient misuses the medication or is suspected of abuse and divergent behavior, that is a serious problem and needs to be addressed. Not so much misuse, but the abuse and diversion, correct, you have to address that immediately. Misuse can just be a result of the patient not understanding how to use the medication, so you need to assess that and determine if this is strictly a misuse or if the patient just hasn't a clue. Lack of effectiveness to meet the treatment goals is an indication or reason why you need to reduce opioids. Keeping a patient on an opioid indefinitely when treatment goals have not been met and functional goals have not been met is not appropriate. Tapering opioid therapy. Current recommendations say decrease the dose by 10 to 50% per week. This is patient-specific. Some patients may have withdrawal at 10% reduction, some will have it at 50% reduction. I would recommend start with a lower fraction reduction, see how the patient's doing, and if the patient has no evidence of any adverse events or withdrawal signs or symptoms, then you could probably lower the dose even by a great amount on the next time that you do a prescription. If you do slow tapering over time, it will help to minimize adverse events and withdrawal. So don't wean a patient in 2 weeks off a dose. I would suggest you do dose reductions every week to every 2 weeks, based on how frequently you can see the patient. In my office, I see patients every 2 weeks for dose reductions. So we go on to say that dose reductions of 10% per week may be appropriate and better tolerated. And I would always err on the side of caution. Like we erred on the side of caution when you initiated a dose, you do the same thing when you're weaning off. Provided the patient has been using your medication, you can then lower the dose by 10% or more per week. Individualize the tapering. Everything is individualized for each patient. So if a patient is not tolerant to a higher dose reduction, then do a smaller dose reduction. Monitor the patient frequently during the tapering. This is extremely important. It will help you to identify and manage any withdrawal effects that the patient may be having. Also consider the use of adjuvant agents such as antidepressants, anti-seizure medications while the patient's being weaned. And refer the patient for counseling and support if it's required during your reduction. When you do taper appropriately, most symptoms of opioid withdrawal are mild, but sometimes these symptoms may last for up to 6 months after opioids have been discontinued. In this event, do not give the patient a low-dose opioid to take care of the mild opioid withdrawal symptoms. By doing that, you've basically not helped the patient or yourself. So do not treat with a benzo or an opioid, either during the time you discontinue or after you discontinue if the patient's having mild opioid withdrawal. In pediatrics, most opioids are not FDA approved for pediatric use, so refer to specific product labeling. I would suggest that you refer to a pediatrician for pain management, as they are more specialized in treating children. For additional information, you can look at the WHO guidelines on the treatment of persistent pain in children with medical illnesses, and there is a website there for you to go to. The CDC guide for prescribing opioids in patients with chronic pain was adopted or created in 2016. It provides recommendations for primary care providers on the safe opioid prescribing practices. The reason being that primary care accounts for approximately 50% of the opioid prescriptions in the country. It does not provide recommendations for treating pain related to palliative, active cancer, or end-of-life care. It includes 12 recommendations grouped into 3 areas. A, determining when to initiate or continue opioids for chronic non-cancer pain. B, the selection of the opioid, the dosage, the duration, follow-up, and discontinuation. And C, assessing the risk and addressing harms of opioid use. And there's a website that I can refer you to look up those. There are also some clinical tools at the website. So A, when do you initiate or continue opioids in chronic non-cancer pain? It is recommended to use non-pharmacological, non-opioid treatments prior to opioids. If opioids are used, combine them with non-opioids as appropriate. 2, treatment goals should be established before initiating opioid therapy. Continue opioids only if the treatment goals are met or if there's been an improvement in function and or pain, and where the function and or pain improvement outweigh the risks to the patient. Providers should also weigh the potential risks versus benefits and discuss them with the patients prior to initiating opioids. Hence, the benefit of having an opioid prescribing agreement in your office. When starting an opioid, immediate release formulations are preferred, especially in an opioid-naive patient. It's important to administer the lowest effective dose and titrate slowly. Monitor for improvement in pain and function when increasing the dosage beyond 50 morphine milligram equivalents, MMEs per day. Doses above 90 should be avoided or very carefully justified in your notes. With regard to dosage, follow-up, and discontinuation, for acute pain, prescribe the lowest effective dose of immediate-release opioids. Do not prescribe for longer than is necessary. 3 days or less will often be sufficient. More than 7 days is rarely needed. When initiating opioids, evaluate the patients within 1 to 4 weeks. Look at the risks versus the benefits and have them documented. For patients utilizing opioids for longer durations, you should evaluate them every 3 months or more frequently if required. In assessing the risk and harms, patients should be screened for risk factors for opioid-related harms, including overdose, before you initiate and then periodically during opioid therapy. Prescribers should review the patient's controlled substances history by looking at the prescription monitoring database or the New York State iStop. This is required, as mentioned, for Schedule 2, 3, and 4. For patients utilizing an opioid for chronic pain, urine drug screens should be conducted when you initiate therapy and then repeated annually. Now, I mentioned this is also based on risk stratification, but the current minimum is screening annually on the assumption that the patient is not a high-risk patient. Benzodiazepines, when co-prescribed with opioids, increases the possibility of harmful adverse effects such as respiratory depression and death. And one has to really consider whether the benzo is absolutely warranted in these patients. If they are warranted, I would suggest that you have a psychiatrist or the primary care document the absolute necessity for the patient to remain on benzos. And if you are going to prescribe an opioid, make sure those patients are monitored not only by you, who is prescribing the opioid, but also by the same physician who is prescribing the benzodiazepine. If a patient develops an opioid use disorder, provide the patient with the proper tools to seek treatment. There is a phone number, a hope line, and the Oasis, which operates a toll-free, anonymous, confidential service to help patients with drug use, gambling, and alcoholism. And patients can call that number and they'll be given assistance on the phone, and it's totally free. I would like now just to go through briefly some cases, and just give you an example of how one approach can be used in these patients, and there are many different approaches based on different scenarios. So case 1 is a 30-year-old male who's seen for low back pain and spasms in the back. He currently works. He's used hydrocodone and Soma for the last 10 years. This was started on an ER visit 10 years ago, where they gave him both hydrocodone and Soma, and he's used to taking this, and it's worked for his back pain. His MRI shows straightening of lumbar lordosis. His examination is essentially benign. The patient states the medication has allowed him to work all these years. His urine screen shows the presence of opiates. And how does one approach the situation? There are many ways one can approach this situation. Most importantly is the fact that this patient's examination is benign. He came in because of complaints of low back pain and spasms, but has a benign examination. Is there any justification to prescribe hydrocodone and Soma? The answer is no. So I would have a discussion with him about the need for hydrocodone and Soma. There is also no indication here that he has used non-opioid modalities. And one may need to introduce those modalities so that you can move away from hydrocodone and Soma use. Granted, it is going to be a bit of a struggle to get him off Soma, given that he's used it for the last 10 years. Soma is highly addicting and almost has the same addiction affinity as long-term benzodiazepine. He does have opioids in his urine screen. One needs to send that urine out and look at the individual molecules and metabolites that are present in the screen, which would lead you to believe that he's been using the hydrocodone as he has so stated. But at any rate, with a benign examination and a patient coming into you with complaints of low back pain and spasms, there is no justification to continue an opiate in this patient. Case 2 is a 50-year-old female referred for further management. The patient has had several spine surgeries. The patient has been on OxyContin 30 milligrams 3 times a day, and hydrocodone, acetaminophen 7.5/325, 2 tablets per day. The exam shows positive findings of lumbar radiculopathy and lumbar spine restricted range of motion. She is requesting the same medication, although she feels she would be better off with raising the dose of OxyContin and taking 2 hydrocodones per day. How do you approach this problem? There are several issues that come to mind. This patient has had several spine surgeries and has an examination that warrants the use of opioids. However, she is asking for an increase in the OxyContin dosing. She still wants to remain on 2 hydrocodones per day, but would like more OxyContin. My main concerns with this particular scenario is that the OxyContin is currently being prescribed as 3 tablets a day. The package insert suggests that OxyContin is a Q12-hour drug. And if you need to prescribe OxyContin, in the current scenario, I would calculate the 24-hour dose, divide it by 2, and write that dose Q12H. The question of whether you're going to increase the OxyContin dose is debatable. Is the request for the raising of the dose based on increasing pain? And if it is the increase in pain due to new pathology? So the question is, does the patient have new pathology that's causing an increase in pain that is making the patient request a higher dose of OxyContin? So one needs to be very careful. Make sure you've evaluated the exam. Perhaps look at a previous note from a physician who she's currently seeing or a surgeon's note who she last saw to see whether your findings are showing increasing restriction or limitations in the clinical findings that would warrant perhaps an investigation such as an MRI or a further review based perhaps ordering an EMG to evaluate whether there's new pathology that requires a referral back to the surgeon or perhaps may require some other interventional treatment which are not just simply raising the dose of an opioid in order to control the pain. There's a third case, which is a 36-year-old male, established patient of yours, stable on Percocet 10-325, 3 tablets a day for the last 12 months. Most recent urine toxicology screen shows oxycodone, oxymorphone, THC, and diacetylmorphine. How do you manage this situation? Several elements are problematic. One is the patient's been on Percocet for the last 12 months. That is long-term unnecessary use of Percocet. This patient should have appropriately been converted to a long-acting opioid and a reduction of the short-acting Percocet to perhaps 1 pill a day used at an appropriate time that the patient required the short-acting opioid. More importantly, the troubling issue is that the urine screen has shown the presence of marijuana as well as diacetyl morphine, heroin. And this shows aberrant behavior. The patient is using the oxycodone and does have oxymorphone. Now, it's important in this particular urine screen to look at the level of the oxycodone in nanograms as well as the level of oxymorphone in nanograms. And the lab should be able to tell you that based on what the patient is using per day, whether the nanograms in the plasma, or in the urine, are appropriate for that dosing of Percocet. I would find it hard to believe that this patient is not misusing the Percocet as well. And I would pleasantly be surprised if the ratios of oxycodone and oxymorphone levels in the urine were deemed to be consistent. The patient is already using marijuana and heroin, and the correct way to manage this patient is to immediately start weaning off the Percocet. Now, could you theoretically just stop writing the Percocet? You could, but the risk is that the patient may have a withdrawal, which he'll come back to you complaining about, and then you'll be forced to treat that. Or just do a 50% reduction, or just reduce the Percocet by 1 pill a day every week until the patient's weaned off. And then start addressing the use of the illicit marijuana and heroin by referring appropriately to an addictionologist and or a psychologist. And that concludes this section of the New York State Mandatory Opioid Training course. I do hope that the data and information I presented will be a valuable tool for you for use in your practices. Thank you.
Thank you for completing Part 1 of the Opioid Prescriber Training Program. Be sure that you complete Part 2 as well, as both portions are required to meet the mandate.